So now we're going to just sort of look at whole body CT in the setting of trauma and sort of get an idea of where we are today with these things. So our introduction will go through a little bit of the golden hour. We'll talk about that, and we'll talk about whole body CT in the setting of trauma. First part will be really what, who, and why we would do whole body CT. And then the second part, sort of a quick run through of how that can be accomplished. So trauma is the #1 killer in people under the age of 46. And it's responsible for about 200,000 deaths per year in the United States. And that's from 2016 data from the CDC. And it's the 4th most common cause of death in all ages in US and Western Europe, and it follows heart disease, cancer, and stroke, but it doesn't really get the attention that those diseases do get. And because it's affecting a younger population, it's responsible for more years of productive life lost than cancer and stroke combined. There's a trimodal distribution of death following trauma, where in the first series of minutes, we can lose about 50% of our patients, usually from exsanguination and severe neurologic injuries. And so really sort of maxing out towards the early hours is our golden hour, and that really is our window of time to diagnose and treat life-threatening injuries that do arrive to the hospital alive. So again, diagnose and treatment occurring in that first sort of window, a golden hour. According to the ATLS, it's not possible clinically to exclude an abdominal or pelvic visceral injury on exam, but going back to even single slice helical/spiral CT, going back quite a ways, has a negative predictive value of 99.6% in the setting of blunt abdominal trauma. So CT really is our workhorse, and that's going to help us really triage these patients. Are they going to be discharged? Do they need to be observed? Do they belong in the IR suite, or do they belong in the OR for managing whatever problems that we find? So really, when you think about an injury happening out on the street, the initial triage has got to be happening on the scene. It's got to be rapid, somewhat accurate at the time, so that they can be quickly and safely moved to the appropriate place. You want them coming to a level 1 trauma center, perhaps, as opposed to, when I was at NYU, we also were running Bellevue, which was the trauma center, and they may be 2 blocks apart, but you don't want that trauma patient ever winding up on the doorstep of NYU because nobody's prepared for it. They're not a level 1 trauma center. So you do need to be in the right place to be able to deal with these. Diagnosis needs to be rapid, it needs to be accurate, but it's in the setting of a very limited clinical exam, and this is really where we get to step up with imaging and perhaps whole body CT if it's appropriate to diagnose bleeding and other life-threatening injuries. And that again leads us to triage with these patients. Do they belong in the operating room? Do our clinical...
We're going to switch topics a little bit for what me has really represented an area where we have the most conflict on call or after hours, and that's the acute aortic syndromes. So we're going to talk a little bit about that. But first I wanted to just begin with a quiz. This is a case that we saw in our emergency department, and just a patient who came in with chest pain. And you'll notice that on the non-contrast images here, we have blood that's clearly not inside of vessels. We have some tracking of blood that is around the main pulmonary artery, and we have this coronal image of the aorta. And the question is, what are we dealing with? Is this a limited intimal tear? What's a limited intimal tear? Is it an intramural hematoma with an ulcer-like projection? Is it a type A dissection? Is it a penetrating atherosclerotic ulcer? Why are we using so many initials, and what do they mean? So let's take a look. This is my favorite park in St. Louis. It's Tower Grove Park. We have yoga every Saturday, and so we can all reflect on our yoga practice and not get stressed by this image and try to go through and make sure that we feel pretty comfortable in an approach in the next 30 minutes. So the term acute aortic syndrome, you may have heard, is a kind of an equivalent of acute coronary syndrome that came around in the 2000s. It was a way of lumping all these conditions that present in the media of the aorta that may present with chest pain. And by far and away, number one, which is aortic dissection, is the most common. Number two is the intramural hematoma. Number three is a penetrating atherosclerotic ulcer. But by far and away, the aortic dissection is the most common. And here, these are the classics, I think, that we've all remembered from our training, that an aortic dissection has a true and a false lumen. It has two barrels that have flow, and oftentimes we'll see a fenestration between the two. An intramural hematoma refers to blood within the wall without a clear connection to the lumen. And a penetrating atherosclerotic ulcer refers to this outpouching that kind of penetrates through the walls, similar to a penetrating gastric ulcer with this kind of saccular outpouching. Unfortunately, what we often see in practice doesn't really follow that beautiful separation. Oftentimes we'll have patients such as this one where you see something that looks like an intramural hematoma in the ascending aorta. We have flaps. How do they fit into the picture? And there's often some blood. So there is not unusual to have patients who have overlap between all of these. So we'll talk a little bit about that as well. So our protocol at Mallinckrodt is that we believe in a true non-contrast study. We have two scanners that are dual energy capable, but we don't find that the virtual non-contrast is very helpful. The ascending.
All right, let's begin. So I have about 20 minutes to cover this very broad topic. I have no disclosures, and I'll just start with a very interesting case that I saw as a resident. This was a patient that was a domestic abuse victim, and as you can see, somebody stuck a knife in her head, and the tip of the knife was very close centrally in the posterior fossa. We did a head CT, which shows that the knife does penetrate through the bone of the clivus into the retroclival cistern, and there's a very important vascular structure in that region, of course, the basilar artery. So this is a very tenuous situation. They did a cerebral angiogram, and as you can see, the tip of the knife actually contacts the basilar artery but does not penetrate it. So this patient was very lucky. The knife was removed, leaving a linear fracture through the clivus, as you can see here. And just as an incidental, somewhat funny add-on here, the report said interval removal of life instead of knife. So now, in this 20 minutes, I'm just going to cover two major parts. We're going to talk about intracranial hemorrhage first, and then we're going to talk about herniation, mostly complications of herniation, which I think is a little bit more interesting than talking about midline shift. I really only have two teaching points, which is that you should always pay attention to the bone-brain interface, essentially the margins of the cerebral hemispheres, and especially along the skull base. These are areas where you frequently get hemorrhage, where fractures basically meet the brain. These are the most common areas to find things, and also the most common and easily missed findings if they're small, because there's a lot of structures, there's a lot of variation along these borders. Number two is if you see a fracture, you should definitely look around the fracture for any kind of soft tissue injury. That could be a scalp hematoma, or intracranially could be an extraaxial hemorrhage, could be a small hemorrhagic or non-hemorrhagic contusion right next door. Conversely, if you see something intracranially that's a focal hemorrhage or contusion, look at the bone right next to it, because you might see a fracture. And I'll show you an example of this, because while making this lecture, I actually did catch a fracture that I missed. So let's start with part one here. So we're going to talk a little bit about epidural hematomas. So this is a 25-year-old female that fell downstairs, has a squamosal temporal bone fracture, which you can see right here, essentially non-displaced. And then you see